recording. If anyone has any concerns about being recorded, please do let us know. So welcome, everyone. I'm Shalia, and this is the First Steps Maternity Support Services and Infant Case Management quarterly webinar. And I will turn it over to Heather so she can introduce herself as well.
Hi, good morning. I'm going to keep my camera off because of this nice cold weather we're having. My internet's been really spotty. I'm Heather Wire. I'm with the Healthcare Authority's First Steps Maternity Support Services, Childbirth Education, and Substance Using Pregnant People programs.
Our agenda today, we will do, these are our welcome slides. Hopefully everyone can hear and the audio is good. So if you cannot, please raise a hand or do something if you're having troubles with the audio. Our presentations today, we will be learning about doula reimbursement and the Washington midwife survey results. We will then hear some program updates and reminders, any last minute questions, and then just a quick wrap up. Our presenters today are from Healthcare Authority. We have Beth, who is a clinical nurse consultant, and Michelle, who is the doula services program manager. And I will let them quickly introduce themselves, and then I'm going to turn it over to them so they're able to go ahead and start.
I can jump in. Hi everybody, Beth Tinker. Thank you, Shalia, for the intro and the picture. I wasn't expecting I'm like, oh, there I am. Some of you I know well. At the Healthcare Authority, I focus on Medicaid clinical policy across a pretty broad range of programs and populations, but including pregnancy services, postpartum services. And so that is my connection to this work, my connection to MSS ICM, just for transparency and connecting. I was a MSS ICM public health nurse for many years. I also supervised a team at Public Health Seattle King County, and I see some of my former colleagues here on this webinar. Nice to see you, and I will pass it to Michelle.
Thanks, Beth. Good morning, everybody. My name is Michelle Madrigal. I am the Birth Doula Services Program Manager at the Healthcare Authority. I have been working in birth work the last 15 years, trained originally as a licensed midwife, was a doula prior to that. So yeah, I'm happy to be here and present on the new doula benefit.
Well, and
Should I?
I do have your slides. Hopefully you see them, right?
I do, yes.
Perfect. And if you're ready, I'll go ahead and start for you.
Sweet. So before we move away from the introductory slide, I just want to provide a quick review of what I'll be talking about today. I will be kind of giving a basic background overview of the doula benefit and the legislative directive that the Healthcare Authority received to implement this new benefit. And then I will give a brief overview of how to become an Apple Health Medicaid doula, and then go over the benefit as a whole. Towards the end, there'll be some resources available, and then, of course, we'll have a Q&A session to answer any questions that people may have. So, next slide. All right. So, last year, during the 2024 legislative session, engrossed Senate Bill 5950 was signed into law by then Governor Inslee. This provided a legislative directive to the Healthcare Authority to implement a new Apple Health doula benefit. With this legislative directive, the Healthcare Authority was allocated funding for two things. So first, there was funding allocated for the doula reimbursement amount, which is up to $3,500 maximum per pregnancy. And then there was also funding allocated for a contract with an external partner to design and implement and create an implementation plan for a doula hub and statewide referral system. The legislative report for this work will be due this year in June, at the end of June. And this will, like I said, this will include recommendations for the doula hub and the statewide referral system, but we don't anticipate that we'll have a live doula hub or statewide referral system until maybe July 2026, assuming we get funding for that in the legislature. And then overall, our initial goal for implementing the new Apple Health Doula benefit was early 2025. And we successfully hit this goal by launching January 1st this year. Next slide, please. So a little overview of what a birth doula is, and you may already know the definition of this, but just to give an overview. So birth doulas are trained non-clinical professionals who provide a variety of services to pregnant, birthing, and post-pregnant people and their families. These services include emotional, physical, psychosocial, and informational support. So for a doula to become reimbursable by Medicaid, they do have to complete a few steps. So the first thing that a doula will need to do is complete their voluntary state certification with the Department of Health. Through this process, they will get a certification number as a birth doula, and then they will need to go and obtain their NPI or National Provider Identifier number if they don't have one already. And then once they have those two pieces of documentation, they'll be able to enroll with Provider One as a billing provider. During this enrollment process, they will need to sign a core provider agreement. They'll need to attest to having obtained professional liability coverage, and they'll also need a business license. They will complete their Provider One enrollment using the birth doula taxonomy. And then eligibility criteria for Apple Health clients. So the eligibility periods for Apple Health clients to receive birth doula services includes pregnancy, birth, inclusive to any end of pregnancy outcome, and or during the postpartum period up through 12 months after the end of the pregnancy. This is important to know or distinguish here. Doula or clients will not be required to start doula services at the beginning of their pregnancy, that as long as they land within one of these three eligibility periods, they will be able to access or utilize the doula benefit. So for example, if they didn't have a doula at the beginning of their pregnancy or during their birth, they're still eligible to receive birth doula services through their 12-month postpartum period. All right, and then we'll go over the benefit as a whole. So next slide, please. So the birth doula benefit is at least for the next 3 to 5 years is going to be will be carved out of managed care and paid through fee for service. What this means is that doulas will only need to complete the HCA Provider One enrollment process, and all of their claims will be submitted through Provider One. As a new provider type to Medicaid, this will hopefully ease their transition into the landscape of insurance reimbursement. But then after those first 3 to 5 years, we do anticipate that the benefit will be carved back into managed care. And this means that doulas will have to contract individually with each managed care organization to bill for and be reimbursed for services. The doula services will still be paid through Provider One on our fee-for-service clients. All right, and this slide is just a really quick overview of what the covered services are. So in general, there is one prenatal intake visit, one labor and delivery support, and additional prenatal and postpartum visits limited to 20 hours per client. And the following slides, I'll kind of give more details about those visits. So for the prenatal intake visit, this is required to be in person and has a 2-hour minimum. It is reimbursed at $750 flat rate, covered once per pregnancy. These are the codes that are associated with it, if you were curious. I think what's important to know about the prenatal intake visit is that within the Birth Doula Services Billing Guide, there are components that are designated for this visit that doulas must complete. And we'll talk a little bit more about those later, but that is something that is also a requirement to this prenatal intake visit. Next slide, please. And then there's labor and delivery support. This is also required to be in person. The expectation is that this is continuous support. So continuous one-on-one support, I should say, meaning that if a doula were to be attending two births at the same time, it wouldn't technically be considered continuous support. The labor and delivery is reimbursed at $750 flat rate, again, covered once per pregnancy. So what this means is that a doula wouldn't be able to show up in early labor, bill $750, and then show up 8 hours later and then a bill again, $750. Again, here are the codes just for reference. And then finally, the additional prenatal and postpartum visits. Again, these are limited to 20 hours or 80 units, which one unit is equal to 15 minutes. In policy, we designated 1.5 hours or 6 units to one comprehensive postpartum visit. And then the additional 18.5 hours or 74 units can be used across the prenatal and or postpartum period, hopefully allowing for flexibility for both the client and the doula and their preferences in where they'd like their visits to land. And these can be used through the 12-month postpartum period. These visits are reimbursed at $25 per 15-minute unit. And again, you can see the codes that are associated with those visits. Great. I'm like, where did we go? So telemedicine is an option for those additional prenatal and postpartum visits that are required to be in person, which I already kind of discussed, is the prenatal intake visit, labor and delivery support, and the first visit with a new doula, if a client chooses to change their doula, also needs to be in person. In order to be eligible or able to provide telehealth visits, the prenatal intake must be completed, or the first visit with the new doula must be completed. Telemedicine visits must be real-time HIPAA compliant audio visual, which means that no audio-only services are covered underneath this benefit currently. The details about this telemedicine policy are outlined in the Birth Doula Services Billing Guide for reference. And then finally, there are limitation extensions that doulas can submit to ask for additional units. So if they exceed the benefit limitations, they will be able to submit an authorization request for this. The approval will be based on medical necessity and special circumstances, and these possible justifications are also located within the Birth Doula Services Billing Guide. Right, and then coordinating care. So part of the component list for the prenatal intake visit is there's language that states that we do anticipate doulas will participate and or collaborate in a co-design plan of care, as well as supporting their clients in establishing care with maybe their pregnancy care provider, as well as coordinating with other medical providers, or within systems such as the MSS, ICM, or childbirth educators. This slide really is an opportunity to kind of ask the question what you may see as this provider type as opportunities for this collaboration and coordination and care, as well as potential barriers that you may anticipate with the coordinating of care with doulas currently. And then we'll just briefly go over the last few slides and then we'll jump into the Q&A. So these are a handful of helpful resources I put together. You'll see a link to the Healthcare Authority Doula webpage, which will tell you all about the background and the benefit overview. And then there's also a link to the Department of Health Birth Doula webpage, which will give you all the information about the voluntary birth doula certification process. And then there's a link to the Birth Doula Services Billing Guide and a link to sign up for doula bulletins from the Healthcare Authority if you're interested. And then, of course, my contact information. Right. And that is everything. So, Beth, if you'd like to jump in and add anything else before we kind of open it up to the floor for questions, feel free.
Yeah, sure thing. Thanks, Michelle. That was really great and helpful. A couple folks have put questions in the Q&A, and Shalia confirmed to me though that everybody can't see them. So I think I'll read the question and then answer the question so everyone can hear the question and the answer. So please put your additional questions in the Q&A, or you can also just come off mute and ask them. Maybe we'll do the couple that were submitted first. I am curious, and Shalia, maybe go back 2 slides to the coordinating care slide, just since we or maybe 3 slides. Curious if anyone has like reactions or thoughts to this and is willing to come off mute. We are very excited that we have this benefit, this reimbursement for doulas, for people on Apple Health Medicaid. It's been a long time coming. Folks at the Healthcare Authority, and certainly doulas and community members have been working on this for more than 5 years. I've been here 5 years, and there was active work on this when I came to the Healthcare Authority. Doulas are absolutely an evidence-based intervention and strategy to improve birth outcomes and infant outcomes. And so it's really exciting, and it's challenging, right? So how to integrate a new provider type into an already existing system, which we all know very well, is not a perfect system by any means, has holes and gaps, lack of coordination, lack of services, geographic differences, right? Like all the things. So, we see you all, First Steps providers, as critical partners. And we are going to figure this out as we go and we learn, right? The doula benefit just was implemented January 1. So we are very much in the infancy stage of the benefit. But yeah, curious if folks have thoughts. Some of you probably already work with doulas, I'm guessing, to some degree. The MCOs have doula pilots. That might be like a current, and prior to January 1 intersection point that maybe someone has comments about, like how that has worked for you in the past in terms of supporting our clients and families and coordinating care. Certainly there are other doulas. There are hospital-based doulas now. So maybe folks have experience working with hospital-based doulas. There are community-based organizations who employ doulas, right? Hummingbird as one, Blackberry, Open Arms, maybe some of these are from. So that's enough talking from me. Does anyone have anything they would like to share?
Very quickly, but I do want to interject. If you would like to ask a question, please just raise your hand because I will have to unmute the person. So, yeah, 2 things. Raise your hand and I will unmute you if you would like to ask your question. And then for questions, you will need to put them in the Q&A box. So there's a chat and a Q&A. Put all questions in the Q&A box. I do have one hand raised, so I am going to unmute her to ask the question. So just one moment.
Perfect. Thanks for the technical assistance, Shalia.
All right, you should be able to talk, Alicia.
Thanks, Shalia.
Yeah, of course.
So this is more of a comment than a question. But anytime we talk about MSS and ICM and you talk about care coordination, I think that costs me more money to do. MSS and ICM already cost, at least in my agency, more than it brings in by a dramatic percentage. And we do it because it's the right thing to do, not because we, ever think that we're going to break even or make money. However, I do get concerned when you guys are talking about care coordination, and I get concerned that there would be another included requirement of care coordination. We love to partner with doulas. We are very, very excited to see the doula program come in. I am concerned that if we add any more layers of stuff that MSS has to do, that it's going to cost more money and make the program less viable to continue.
Yep. Alicia, thank you for that comment. And Heather, interrupt me if I misspeak in any way. We are not talking about adding any additional requirements in terms of MSS and ICM providers. This is more like a broad context questions of, and maybe I should be, I mean, I know care coordination means, well, actually, care coordination is used all the time and means different things to different people. But in the context of MSS, right, where it is an explicit service that is reimbursable. Yeah, we are not talking about adding requirements. We are so maybe we rephrase this as collaboration, right?
Beth, it is in WAC. The doula WAC and the MSS WAC is going to include care coordination between the MSS provider and the doula provider. It's in the doula WAC, and then I'll be adding it to the MSS WAC because we have to ensure that there's no duplication of services.
Okay. Okay. Heather, it might be helpful for this audience if you have time to pull it up to pop it in the chat. Oh, sorry, not the chat. People can't see it. Never mind.
Yes, so it is something, and that's why we're working on increasing the reimbursement rate, which so during our updates we'll be adding that, but with the reimbursement rate and things, because we do know that there's a lot that the MSS providers are doing, but that is in the doula WAC currently that's being worked on, and in the doula billing guide that they're to coordinate. Let's see.
It's broad.
Activities.
Yeah.
With the First Steps MSS provider, and then we will be also updating that within the MSS WACs.
Okay. Thanks for correcting me, Heather.
And Beth, I don't have any more hands raised now, but we do have several questions in the Q&A box, so I will go ahead and let you do that.
Okay. I will read them in the order they came in. The first question, what if you don't have Medicaid and have insurance through your employer? Can I still access a doula and have it paid by my insurance? So I did type this in, so I'll just read what I typed. I think only the person who asked the question got the response. All of this information that Michelle shared, is specific to those covered on Apple Health Medicaid. Most private commercial insurance does not currently cover doula services. But the broad recommendation would always be for someone to check with their own insurance and ask about covered benefits, right? So specifically, if doula services are covered, we do know that TRICARE covers doula services as one example. That's the end of what I wrote. I would also just add onto this that we hope, and I think expect to some degree, that other insurers, commercial private insurers, will come along, and that future state there will be additional coverage for doula services. But again, to just loop back to your question, what if you don't have Medicaid? This presentation and our work is only for those on Apple Health Medicaid. Does that answer your question? It was an anonymous attendee, so I'm not sure who it was, but you can raise your hand if that did not answer your question.
I do have a hand raised, so I am going to go ahead and unmute just in case that was the person who asked that. So
sure.
All right. Is your Dana? I'm not sure if I'm saying that correctly, but you are unmuted if you would like to talk.
Good morning. Thank you. Yeah, it's Dana, and I am not the person who had asked that question. I just had a few moments to kind of formulate some thoughts in response to the provider's question about adding costs to the MSS and other programs. And I just wanted to suggest that there are providers who have working relationships with maybe social workers and other non-clinical services and communities where they develop kind of a working knowledge of who's who and develop a preference over time of who they like to work with most because of whatever number of reasons. And I would think that this would be kind of a similar situation. There are many doulas who may not be coming to this work with the kind of background that maybe providers are used to. So there will be that period of time of adjustment and helping them understand how to communicate and coordinate in this environment by setting those expectations, right? Whereas there are other doulas more like myself who are coming from a social work and clinical and hospital care environment, public health background. So I know that if I ask a doctor for 5 minutes, that's literally all I need. In, out, I've got my questions answered, I can move on. But that's been my experience already in reaching out to providers to kind of see where I can develop an alliance. There is quite a bit of resistance and pushback because they don't know who I am. It's a huge, diverse population with a small number of doulas, right? We're varied, very varied in what we bring and provide. And I just think that it's a really reasonable question to ask, because the added cost is how much time is it going to take the market, right? The providers to respond to this non-clinical supportive role. Because it really could take quite a bit of time, I would think. And that's reasonable to ask.
Yeah, Dana, thank you. I appreciate your comments and your insight. I don't know that I have, like, Heather, do you have anything to respond to in terms of the care coordination piece?
Yeah, that's one thing is we don't really have specific on the care coordinator. It's up to the providers how they want to do it. So I do know that some may just kind of send out some emails and just touch base with that. And then I see a question came through in regards to my comment where I said duplication of services, because with Medicaid, we've always got to be careful that we don't have providers providing the exact same type of service. Not really, I'm not meaning by type, but kind of you want to ensure that a client's receiving the services that they need, but we're not having two different provider types telling them the exact same thing and over and over. We want to make sure that the services being provided are kind of catching everything and helping to ensure that they're receiving what's needed. So I don't know, I don't know if I'm being very clear or not, but that care coordination, it is kind of seen as a crucial, but we definitely don't want to make it that it is burdensome and going to be costly. We just kind of want to make sure that what's best for the client is being provided to the clients.
Shalia, do you see any other hands on that topic? Or, I mean, I know we don't
No,
know,
so
but
no,
okay.
no hands raised at the moment. So if you want to go back to the Q&A box, you're good.
Yep.
Yeah.
The next question is from Lika. Is it possible to have someone from your agency to meet via Zoom with our community members? I mean, Lika, I think broadly, the answer to that question is like we are always willing to, as much as we can, meet with additional folks. We work really hard at being available, and like we only have so many resources and time, and I'm sure everyone's well aware of our state budget scenario. And there's a lot of there's a lot of freezes on us in terms of, you know, what we can do, and we are absolutely having to be more judicious with like our time and prioritizing because we're gonna have less staff and less resources to do more work. So I'm curious if you don't mind coming off mute, Lika, because raising your hand. I feel like others might have this question, and I'm curious about what the audience is that you're thinking about, that we would meet with, and if that audience, in reading the doula webpage, and basically the resources in the PowerPoint, which I think is going to be shared with you all afterwards, so you will have those links to this. If there's sort of remaining gaps that you feel like really are important that we would be available to speak to, that would be helpful.
I do have one hand raised, so I will go ahead and unmute. Oh, looks like it's Tanaya. So you are good to talk.
I don't want to put Dana on the spot, but I'm wondering if we could hear from maybe an example or a case study where a clinical provider has worked, or an MSS provider has worked with a doula. I know that it's happening because I've seen the claims, and I want to see like if we could map out like a process flow. I don't know if that would be helpful for other folks when we talk about um barriers and some challenges, but seeing a success story and how some of these things were worked out. Always just giving an example, and but maybe Dana, she was kind of hinting at some things, and I just kind of want to hear from her or others. Thank you.
Wonderful. I can give just a minute to see if any other hands are raised to answer that question or respond to that question. I don't have any hands raised now. What we could do, Beth, is go back to the Q&A box, and then
Sure.
I'll let you know if someone else raises their hand. Thank you.
Sure. Yeah, that sounds good. Everyone, I'm sort of going to combine like the rest of the questions that I see, which all, and Michelle, maybe you've been answering it in the chat.
Yeah.
The broad question is, how do I find a Medicaid enrolled doula for my clients, families in my community or in my area? Michelle, do you want to take this one?
Yeah, of course. I didn't.
Sorry.
Yeah, that's okay. So the primary way currently that we have, which isn't necessarily the best way, which you can see in some of the answers, is to use the Find a Provider tool, the Healthcare Authorities Find a Provider tool. It is a little clunky and it's not always accurate. And so sometimes if you search just by city, so for example, it looked like someone looked just in Seattle and they didn't see any doulas in that area. But if you broaden the search to by county, you'll be able to see a handful of doulas that'll pop up by county. So that is the one, if we're using the Find a Provider tool, I highly recommend searching by county as well as searching by surrounding county. If you go in and play around, you'll see that there are very few doulas that pop up, and that is true. Our enrollment numbers are continuing to grow. So you won't see, 15, 20 different doulas pop up in your region yet. So Find a Provider tool is step number one, I would say. And then I did see that someone mentioned doula match in there as well as a way to find doulas. The sticky thing about doula match is that not all doula providers are a part of doula match, and so you could be potentially missing out on doulas that choose not to participate on doulamatch.net. They do have the ability to kind of filter out the doula that you're looking for. So by experience, services they offer, Medicaid, hopefully, I haven't been on Doula Match to see if they've updated their insurance coverage to include Medicaid, but you might be able to identify doulas that way. And then we're also encouraging clients, Apple Health clients, to reach out to their pregnancy providers to hopefully gather some resources and identify doulas that they recommend within their region to support services.
I have something to, Lika, thank you for the detail. Oh, sorry, people can't see this. I can't get this through my head. So, Lika responded that you work with or have Pacific Islander doulas for a presentation. Lika, I think the most helpful thing would be if you can email the doula mailbox with the connection person that you have for the doulas, and we can communicate directly with them. And certainly like CCU if you want to be on that with the resources, and have them first look at the doula webpage and the billing guide, which is quite detailed, and see if that answers any questions that they have. And if not, then we are happy to connect with them. Because the other thing that does is we're trying to build resources that are available to everyone that are helpful and actually answer people's questions. And so if we hear from groups like, yeah, we read your FAQ and we read the billing guide and we still have all these questions, that's really helpful feedback for us because we can update the information that we have, if that makes sense. So Lika, if you're willing to connect us to them, we will follow up. The only other thing other than Michelle said that just came to mind for me, suggestions for creating capacity and developing a pathway. So Michelle already talked about, potentially we will have a hub, including some kind of more organized statewide referral system in the future. But that is not now, and that is frankly unknown because it will require legislative funding. So anytime that is the case, right, we have no guarantee. What I might ask or like request or something for everyone to consider is as you talk to doulas in your community, as you come to know doulas, encouraging them to enroll with the healthcare authority, and become a Medicaid enrolled provider so that they can provide services to Apple Health Medicaid clients, and bill for them. Like we really don't have a way of knowing who all the doulas are out there across the state. Michelle, did you kind of give the current stats? I don't think so. We currently, I mean, this is dynamic and a moving target. This may not be 100% correct as of today. But like earlier this week, we had 7 enrolled doulas with the healthcare authority. That's like a count of 7 for the whole state. Depending how you look at that, that's good. The benefit just launched January 1, so we have 7. That you could frame that as like a good thing and exciting. And certainly 7 doulas across the state are not going to serve the Apple Health covered population, right? We cover 36,000 births a year in Washington. So you can just see that is certainly, that's a start. And we are hoping to see this pathway, right, continue to grow over time. More maybe like, or an additionally hopeful piece of data is that we have 30 pending, Michelle? 20.
Yeah, 30.
30 pending. 30 seems great, right? Way more than 7. 30 pending. That means these are doulas who have gone through the process and have submitted their application, and those are just being reviewed by another team that we have at the Healthcare Authority, our provider enrollment. So anyway, right, like what we think that we will see is a somewhat gradual, but maybe increasing enrollment of doulas. And I think MSS and other providers in the perinatal space, as well as clients themselves, asking doulas if they are enrolled in Apple Health is really going to help, right? So like, how would that happen from the client perspective? We think that there's going to be clients, Apple Health Medicaid covered clients, who become aware that the doula benefit is covered, that there's a reimbursement by Medicaid. Clients are going to be interested and are going to want a doula, and they are going to start searching, like, right, on their own, like Google searching, using social media. There's various kind of Facebook and other groups currently for doulas. And then clients potentially, right, will be reaching out to a doula and asking them if they can provide them services as an Apple Health provider. But what needs to happen is that doula will have to enroll with the Healthcare Authority in order for that to happen. So, Michelle, anything to add? I hope that was helpful. That's just kind of where we're at.
Yeah, I think that answers the question why we're seeing, if you look in Thurston County, there's no doulas. Someone in the chat did ask about the CMAR popping up. And Beth speaks to this a little bit better than I do, but we think that CMAR is an old artifact from the past. So they, within the Healthcare Authority, they have the doula taxonomy assigned to their clinics, and so they show up as an option. But it is true that currently, to our knowledge, they don't have doula servicing providers working underneath them right now. So that was the caveat with, using the Find a Provider tools. It's not entirely correct when you're trying to find a doula who is currently serving the Medicaid population. So, but no, I think what you said, Beth, I don't have anything else major to add.
Okay. I'm looking at Shirley and Heather. I just want to call out the second slide deck on the midwife surveys. Like I feel like this is really helpful. And if people continue to have questions that we can answer, I wonder if we defer the other content to a future meeting and just focus this on the doula benefit. I'm totally fine with that. And if you guys are.
I mean, I'm good with whatever you feel like you're comfortable covering in this time period. If you want to move on to the other slides, and then we will answer what we can at the end, just to make sure we have time for the other slides. Is that okay?
Yeah. That's fine. I can totally breeze through some of them. Okay, let me just make sure that
I will go ahead and pull it up. So give me
okay.
a minute. So whenever you are ready, Beth.
Okay. I'm gonna shut the Q&A because otherwise I will be distracted because I'll be looking at it. But feel free to keep putting things in it. That's not what I meant. Oh wait. On my own screen. Okay. So everyone, this is a different topic, still in the birth worker space, still in the perinatal space. I wanted to share with you all some results from two different surveys. One was a survey that was put out for midwives, practicing midwives, and the other was a survey that was put out for clients to respond to. The overall reason or objective for these two disparate surveys to these different audiences was the same. So essentially was really exploring how do Apple Health Medicaid clients hear about midwives and midwifery models of care? What are the mechanisms? You'll see on the slides, we call them acquisition channels. Basically, it's like the ways, the routes, the mechanisms. Like how are people hearing about and learning about midwives? And then to some degree, why do sort of like a secondary objective, why are people choosing midwives for their care who end up with a midwife as their primary perinatal clinical provider? So next slide, Shalia, and then it's just the next slide. Just want to say these slides, if you've noticed, these are not branded on the HCA slide deck. The slide content is not like property of the Healthcare Authority specifically, but this is really shared content that came out of a learning collaborative that Washington participated in, an Institute for Medicaid Innovation 3-year learning collaborative. There were various partners on this group. Healthcare Authority was one of them. I think some of our other team members are on this webinar from MCOs. So there were community-based organizations, there were a variety of partners. So just my thanks to our Washington team for their work on this project. And again, these slides are owned by the entire Learning Collaborative. Okay, next slide. So this is around the midwife survey. So we launched it, you can see when, May to July 2023. We got what we were really happy with this response rate from midwives, 177 unique responses with 3 potential duplicates. So those were not removed. We just made that decision. But just calling that out. So who were the folks who responded? Basically on these slides, I'm gonna give like one key takeaway because I think that's what we probably have time for. So you can see by practice type, there's a lot of colored pie charts in this slide deck. Hopefully that works for folks. I'll try to orient you again to sort of a key takeaway. So you can see that 50% or so of those who responded, right, which was a sample of 177 were hospital-based. In terms of race and ethnicity, we'll just call out the purple, dark purple, the largest, the 85% of folks self-identified as white. Next slide, please. County served, these were multiple choice, so don't anticipate that these would add up to 100. Probably no surprise to anyone. The county served is really sort of falls in line with population of counties. So, right, so you can see by the length of these various bars, all in purple, where people responded, you see King, Pierce, and Thurston? Yeah. As I'm surprised Snohomish. Oh, Snohomish also. Yeah, top three look like King, Snohomish were the top counties that midwives responded that they were serving clients. Next slide. Size and payer mix. So this was really around the size of the practice. That is the pie chart on the left. So let's just highlight the darkest brown, sort of mocha coffee colored, maybe. Almost half of folks responded that they serve over 100 clients a year. In the pie chart on the right, this was about payer mix. And so you can see, let's just look at the 50 to 75 and the 75 to 100. So the gray and the gold color combined is about a third, right? So that they serve more than half of the clients that they serve are Medicaid. Actually, in the Medicaid clients, I mean, essentially what you see, I guess, key takeaway, like fairly even distribution here, other than the less than 10% is clearly a smaller piece of the pie. Next slide. We asked about if their practice, if themselves as a midwife in their practice, serve specifically any communities of color. And so there was a free text, which is where you see here on the left, specific populations that were called out. On the right are just some sort of summary observations. Which one do I want to call out? Again, about over 50% were hospital-based practices. I suppose of interest, this is going to come up later. Look at that last bullet, 91%, right? So overwhelming these practices find clients via word of mouth for those who specifically serve communities of color. Next slide. I feel like I'm talking really fast. I'll try to talk. Michelle, am I talking too fast? You can nod. No, it's okay. Okay. Acquisition channels. So I said at the onset that this was actually sort of like the crux or the overall primary objective of this survey. This was a midwife survey, and we'll get to the client survey, right? How do your clients find you? And this is from the midwife perspective, right? So how do midwives, what do they know and understand about how their clients find you? Major takeaways here are you can see the top is word of mouth. Very interesting. Digital acquisition is the second most common cited. And then you sort of get to insurance and other providers, followed by community-based organizations. So like, what's a takeaway? There's a range of ways, mechanisms, acquisition channels for which midwives believe and understand that their clients are finding them, but clearly word of mouth, friend or family member, current or former client, and web-based searching or social media, digital acquisition. These are all very important mechanisms for people to find a midwife. Next slide. These are really meaningful, as quotes always are. And we don't have time to read all of them. So you're all probably reading them now. But we asked about if, again, these are midwives, right, responding to their survey. We asked them if they see or experience differences in how their clients on Medicaid find them versus their clients who are not on Medicaid, who presumably most of them have other insurance, right, private or commercial insurance. So you see Medicaid clients mostly hear about us via their insurance carrier from one provider. Another provider says Medicaid, I'm reading from the middle. I'm going to focus in on a couple of these under the differences by acquisition channel. So the second quote, Medicaid probably more often finds us through Google. So that's that midwives experience. Further down, so you kind of see the whole gamut here, right? Which is what you get with qualitative data, but it's always really interesting and meaningful. Medicaid client, word of mouth, history of experience with us. This midwife said that private insurance more likely hears about us, me, my practice through other health care provider or the website. Another midwife said Medicaid clients are more likely to hear about me from a community-based organization. So yes, I think I will stop there on this. I'm sure folks read others of them. Next slide. We did do a little bit of like a deeper dive in terms of midwives who identify themselves as Black or African American. So you can see out of the respondents, only an N of 12 identified as Black African American. What do I want to point out about those practices? You can see that they served Medicaid or practice type. Which one of these is the most interesting? I mean, I would say, so look at the pie on the left upper corner. This is around practice type. So again, these are 12 folks, so we cannot and should not generalize or, you know, make assumptions from this really in any way other than like, that's interesting. And maybe there's more questions here to pursue, but you can see community licensed midwives certainly are overrepresented there in terms of practice type, right? Practice setting for those small number who identified as Black or African American. Okay, next slide. I'm gonna try to finish this by 11. I feel like that's ambitious, but okay. Client survey. So this is a separate audience. We did ask some of the same questions and some slightly different questions. Again, our Learning Collaborative team, this is the work of the team. Many thanks to our team for all of their work on this. Look how many responses we got. Every time I see this slide, I'm like, I can't believe we got almost 1,000 responses. This survey followed the midwife survey. It was a little later. Basically, that was because of the time that it took for us to translate the survey and figure out how to disseminate it and sort of all the operational pieces. There were plenty of barriers and hurdles to get over. We actually had the survey translated into the languages you see here, as well as Mandarin and Somali. But we didn't have any responses in those languages, which is why they're not listed under the responses. Okay, next slide. So what were the goals of this analysis? Hopefully this is familiar to everyone now. We wanted to understand why people seek out a midwife and how they find their midwife. And we wanted to dissect a little bit the responses and the data that we got by birth setting, by race, ethnicity, and language. This is clients this time, right? The survey, and then also a little bit by state geography, both in terms of maternity care deserts. This was using the Tanaya. Oh, you can't talk. The maternity care desert definition, I'll think of it in a second. And we also used rural versus urban. Okay, next slide. Demographic review. So who were the respondents? This was rural versus urban. So you can see in the map, again, you see like heavy responses from kind of I-5 corridor, Spokane also represented there, as well as Clark County, maternity care deserts. Michelle, do you remember them? You weren't even here. You're like, I had nothing to do with this. Yeah, that's very fair. Overwhelmingly, those who responded were in a full access area, less in low access and maternity care desert. And then you can see, right, significantly more, 78% from an urban area, but actually 22% representing a rural area, I think is great in terms of variation in clients who responded. Next slide. Again, these are clients, right? Language spoken, almost 90% identified as English as their primary language. You can see the ethnicity data and then the race data. I think we can go to the next slide. Birth setting. I think this is interesting and not surprising. When our IMI team reviewed this and discussed kind of all of these results and what we made of this, I think our conclusion was like, we know that there's confusion around midwives and different types of midwives, because you can see here in the pie chart on the right, we asked for folks who had a midwife or currently have a midwife at the time they completed the survey for their primary perinatal clinical provider, what type of midwife, whether it was a licensed midwife, a certified nurse midwife, or unsure. So baseline, you see a lot of folks are unsure. The part where we were like, yeah, we don't think, or this is not really confirmed or aligned with other data, that 30% are seeing a licensed midwife. So that's why you see here in the note that it's unlikely. And that's okay. I mean, we are not trying to change this. I think other than having awareness that perhaps clients are not certain of the type of midwife that they are seeing. And of course, that begs the question of, does it matter? Which is a different question, but this is what we heard on the survey. Next slide. There's a lot here. What is a takeaway here? I think the takeaway is what's written out underneath the title of the slide, which is that non-Hispanic, white, American Indian, Alaska Native identifying respondents were more likely to birth in community settings than other race and ethnicity groups. Again, not that that's an issue or something we're trying to solve. It's just something of interest and how our respondents responded to this question. OOH, if folks aren't following in the pie, that is out of hospital. Compared to hospital, so you can see pretty similar there. No real difference between English preferred and English non-preferred. Oh, in the other graphs under ethnicity and race, the graphs that have the little bars around that is when there is not a statistically significant difference, but a difference that we felt like was worth pointing out between, in the ethnicity, it's between Hispanic and non-Hispanic. In the race on the right, it is between birth setting. So you can see home birth, birth center, and hospital. I did not finish by 11. Okay, next slide. There's really not a lot of differences here. This was just another way to look at the data. So I think we're going to go to the next slide. Okay, how clients find a midwife. So here are the top 4, very aligned with what we heard from the midwife survey, which I will say is what we expected. I think we all said we think midwives know how their clients find them because we think midwives tend to ask clients or have those conversations with clients. And it turns out what we learned from these surveys is for those who responded, that seems to be true because there was plenty of alignment between the midwife survey and the client survey in terms of these acquisition channels: word of mouth, internet search, another healthcare provider, and MCO. Next slide. So I'm going to point out, if you can draw your attention to the right, acquisition channels ranked. This was like a comparison of sorts between the midwife survey and the client survey. And so what I will just point out as a takeaway for both surveys, the top acquisition channel was word of mouth, and then internet search. And then you see some with more midwives overall responding those two, but still, right? Like alignment here. And then you see more divergence as you get down to the 3 through 10, but not, still the same acquisition channels really are elevated, just some variation in terms of kind of the number of respondents who highlighted those mechanisms or acquisition channels. Next slide. Birth setting informs behavior. So again, I think the big takeaway that top 4 acquisition channels, regardless of the birth setting, were word of mouth, internet search, healthcare provider, and MCO. There are some subtle differences, and what we took away as a possible suggestion, although we cannot say that, and this is not absolutely like a result of this survey. It's an interesting finding, and it may suggest that there is some bias in provider MCO guidance that informs awareness of birth options. Why do we say that? Because if you look at let's just look at the 3 on the right-hand side, the way that these are organized, what you see in the colored bar graphs are the acquisition channels, right? So you see internet search, word of mouth. And so when you look at the MCO, the dark, right, it seems that there is, there are some differences there represented in the data. Next slide, please. Language. So a lower percent of our clients who responded who have a preferred language other than English. They seem to have as a reported acquisition channel. Lower on the list was internet search. What does that mean? We don't know, right? It's interesting, maybe not surprising, but what does that mean? Is that a preference, or is that there is not information available in their preferred language, and for that reason they're using other acquisition channel? Well, actually, that's not what it's saying. That they are reported using internet searching less than other groups. So interesting finding. We don't know exactly what it means, but something notable. Next slide, please. Pretty consistent across race, right? Again, what are we looking at? We are looking at those top acquisition channels. And so just another way to look at the data and say, do we see differences? The two arrows there. So let's hone in on the Native Hawaiian, other Pacific Islander group. This is only an N of 26. So like all the caveats that we've already talked about certainly apply. So it's just sort of like interesting, right? Is it suggestive? And is it that Hawaiian and Pacific Islander folks have lower, so the gold color you can see is the word of mouth. That is lower here in terms of folks who responded and identified as Native Hawaiian or other Pacific Islander. And you can also see that the gray, the healthcare authority bar as a direct acquisition channel was more reported by those who identified as Hawaiian or Pacific Islander. Okay, next slide. Geography, similar here. There's really no variability that jumps out. The numbers there that you see in the middle, again, those are the rankings of the acquisition channel, right? You see word of mouth, you see internet search as 2 and another provider, but really no real variability here that jumps out. Next slide. Why did clients choose a midwife? The colored, what are these color? Well, you guys can see they're gold. It's gold and it's like a muddy red, maybe. These are responses. This was an open text field. So these are responses that clients entered. These are in alphabetical order. So these are not prioritized or ranked. So I'm probably going to go on to another slide where they are, but basically you can just see here people voice choosing a midwife for a large variety of ways. I think folks who are midwives, Michelle's a midwife, I think all of these resonate. We've certainly heard that from midwives who were in our learning collaborative group. Next slide. It's going to be a word cloud. So the biggest, folks know word clouds, right? So again, the question here was, why did you choose a midwife? And so you can see natural, personal, support, better help, holistic intervention, safe. These were sort of the most common cited responses that clients who responded to the survey had for that question. Next slide. Okay, so now here's the sort of rank order of what folks responded. So you can see there at the top, desires natural birth. Very much something that client said is the reason, or one of the reasons. People could certainly put multiple things in this text box, and they did. Support and comfort, personalized care. Return client shows up there. This passive assignment in the dark was something that very much interested us from the beginning. Like, what is that about? And there's another slide. So next slide, please, Leah. Oh yeah, I forgot about this. So like we did kind of in all of the data, one of the ways that we sliced it was looking at it by birth setting. essentially you don't see major differences here, right? So if you just compare at-home birth center and hospital and you look at the colors, I mean, yes, there's a slight amount of difference, but really the top 3 and 4 are the same across the birth settings. Next slide. Oh yeah, the Russian survey. So this is looking at those who reported that English is their preferred or primary language versus those who reported that another language is their primary or preferred language. And you do see some differences here. Draw your attention to the second pair, which is knowledge and expertise. And you see that way higher, significantly higher, in the English as a second language group. What is that about? We don't know. I mean, we have some guesses. Certainly, if you look at pregnancy care globally, most places in the world, midwives are the primary clinical pregnancy provider. So certainly we think that is part of it. And you can see here the note on the Russian survey in particular. They wanted to see a specialist, someone who was an expert in pregnancy care, and some people certainly who responded elevated that those are midwives from their perspective. Next slide. Hispanic and non-Hispanic. So again, you can see here some differences, a shift in terms of Hispanic and non-Hispanic, where more Hispanic reported support and comfort. This is the passive assignment. So, right, these were folks, when the question was, why did you come to choose a midwife? That we had a number of respondents who, shared they didn't necessarily choose a midwife. They were assigned or they were given a midwife, and it wasn't something that they explicitly chose. So this was really looking at that by ethnicity, language, and race. And so we do see here some differences, particularly look at the language in the middle, where you see more folks with English as a second language who reported they were passively assigned a midwife as compared to English preferred respondents. Next slide. This is the last slide. So what does all this mean? We, in terms of our learning collaborative, don't really have time to share sort of the other efforts that we took as a team, and there still are ongoing things. But marketing certainly comes to mind, right? Knowing and understanding what the primary acquisition channels are. Do we have, what are the ways in which we could increase knowledge and awareness of midwives to our Apple Health Medicaid clients? I suppose I should say really quickly before going back to Q&A for probably a minute or two, because I know Shalia and Heather have other updates. We believe we are aware of and certainly support the evidence behind midwives and midwifery models of care that for low risk births, right? So folks who are anticipated to have a full-term vaginal delivery broadly, that midwives have better outcomes. And I'm sure you all probably are aware of that and the multitude of reasons behind it, many of which came up on that word cloud, right? Or were in this slide deck about the reasons why people choose midwives. And so we are keenly interested and invested in promoting awareness of the option of midwives for our Apple Health clients. And I mean, when I say all of that, we also just believe it is the client's choice. And we want clients to make informed decisions about their care and the type of provider that they want. And so by no means are we talking anything about forcing or requiring the clients to have a midwife. But we do want clients to be aware of the benefits of midwives and that midwives are an option for them. As well as various birth settings when they are covered by Apple Health, including hospitals, freestanding birth centers, and home birth. And I'm done. That was my last slide, right, Shalia? I mean, I hope so. Yes.
Thanks, Beth. And there was a question that came in that says, how do you get assigned a midwife?
Yeah. I don't know. I have some guesses from working. Here's what I think. I think a client can show up to a practice, or actually, they can show up or they can call, right? And say, I'm pregnant and I'm looking for, care for my pregnancy. And I think that there are processes that happen at some healthcare delivery settings or sites where folks are maybe screened to some degree, because high-risk folks should not be seeing midwives. Folks are screened and they are like assigned a provider. I think that's what happens. Because there are certainly OB practice settings where there's multiple provider types, right? Where you have like CNM, certified nurse midwives, you have maybe family doctors, that's less common all the time, but like OBGYNs, right? So there's mixed licensure in a practice, and how clients get connected with, say, a certified nurse midwife versus an OBGYN. I think that is probably when people reported that they got assigned a midwife, that they didn't make that choice. That was who they were scheduled with, and that was who they ended up seeing.
Oh, and I thought I was texting Shalia to ask if she could do something, but I just realized it was to my kid. Shalia, I want to, if you're able, can you go to the hca.wa.gov website? I want to show everyone the client side of the information that both Michelle and Beth have shared, not the specific survey, but in regards to the information that we have online for midwives and just kind of our general client pregnancy website, because I think a lot of times we share the provider side, we don't share the client side. So Shirley, if you're able to go to hca.wa.gov.
Yes, let's see, it's pulling it up now. Wait a minute, hold on. I think I went to the wrong side there. Okay, I will share now because I think it unshared. Okay, and all right, should be, let me know if you see it.
Yes. Okay. So on hca.wa.gov, if you click on find affordable healthcare, down below the red,
Oh, thank you.
that kind of takes you to the kind of our client facing website. And if you scroll down, this is going to be the easiest way to get to it. Oh, never mind. Go back up. I just had it, but it's click on find covered services and see if you're eligible. Okay, when you're on that, now scroll down, stop right there, and then under am I eligible, there's one that says pregnant individuals. So if you click on that, it kind of gives the overarching like who would be eligible, like what the eligibility requirements are. So if you scroll down, it kind of gives what the federal poverty level requirements are and things such as that. And if you keep scrolling, so it gives that program requirements, talks a little bit about the after pregnancy coverage, how to apply, and then keep going. And then it has related links. And if you click on that pregnancy services under related links, kind of takes you to our pregnancy website that has some general information as to what's covered through the First Steps program, the overarching pregnancy medical. And then if you keep scrolling down, it's again talks about the after pregnancy coverage, takes you to that direct website, the First Steps Enhanced Services sub program. But then if you click on type of care provider, the caret there, that's where you'll find some information in regards to birth doulas. And so this kind of might give you some language to help when you're talking with clients. And then also it talks about the certified nurse midwife, and if you can scroll down, it just gives a little bit more information that might provide some additional talking points when you're working with Apple Health enrollees. And so we have that provider side, which I know we share with you guys a lot, but I just wanted to make sure you were aware. There's also a client facing website. And then it also talks about the different types of birth settings. So that's always something good to bookmark this page as well.
Great, thank you, Heather. Not sure, Heather, if you wanted to do some more questions or if you wanted to jump on over to our updates.
I don't see any more questions coming in, but if you guys do have any questions, please let us know. We can always send them to Michelle and Beth. I'd like to say we work together. We don't, we're all at home working, but we have our teams. We're constantly messaging each other and have meetings together. So we do work closely with Michelle and Beth. I want to thank you guys so much for being willing to talk about the work that you guys have been doing. And I'm so excited that you guys were able to get the doulas started on January 1st. That was awesome. You guys did a ton of work.
Yeah, that's amazing. Thank you for all your hard work.
Great. So I guess we'll go. It looks like I think we have 10 minutes. So I will try and talk fast, but not too fast that you can't understand me because I'm really good at that. So just wanted to quickly mention about the Apple Health Expansion, or as we call it, AHE. It's a capped enrollment program that I believe was open this summer. And it's for individuals who do not meet the citizenship or immigration status requirements for the other Apple Health programs. The reason I'm bringing it up here is because those who are pregnant or had a pregnancy end in the last 12 months are not eligible for AHE or Apple Health Expansion, as they qualify under the Apple Health Pregnancy Medical or the After Pregnancy Coverage programs. So AHE is a state-funded only program, and if a client is on AHE and receives MSS and you're an FQHC, be aware that the encounter rate won't be paid because of the type of coverage that they're in. So if you are working with somebody or you're going to see somebody that's on Apple Health Expansion and they are pregnant or within 12 months postpartum, strongly encourage them to contact Health Benefit Exchange or the Healthcare Authority, whichever is the most appropriate, to report their pregnancy or the end of their pregnancy so that they can get on the correct Medicaid eligibility program. Next, I spoke last time at the webinar that we were fortunate to get a University of Washington Doctor of Nursing practice student to be part to be part of a project in regards to our MSS screening tools. And part of the project, besides doing the literature review, is she's also going to be doing, and her name's Takara, she's going to be doing a listening session to talk with those of you MSS providers who are using the required tools to just kind of get some feedback. And so she just got them recently hot off the press, some dates that work best for her. The first is January 30th. And then if that doesn't work, we also have a February 7th date. The time would be from noon to 1. So if you are interested in being part of the listening session with her, January 30th or February 7th, please let us know. I know we've gotten a couple volunteers. I will be reaching out to you to let you know those dates to see what's going to work. But yet hot off the presses, so I haven't had a chance to do that. But if you are interested in volunteering to be a part of the listening session, please email Shalia and myself at hcafirststeps@hca.wa.gov, and we'll have at the end I think there's a slide that has the team email. So if you're able to attend either the listening sessions and want to, please let us know so that we can get that scheduled. It will be done through Teams. Online screening tool. As we mentioned at the last webinar, we're still working on the MSS getting the current MSS screening tools into an online system. We've been working with HCA's IT folks to get that in. I think we're getting close, hopefully fingers crossed, to testing it. Shalia and I, and then Tanaya, who spoke earlier, we'll be testing it and trying to break the system. And then after that, we will be needing some volunteers. Some of you who are currently doing the screenings, if you'd like to volunteer to test the system and try to break it as well. We're always looking for volunteers. So please reach out to us, send us an email if you want to get on the list. We do have a list that we've started. So We will be reaching out. I don't know if we don't have specific dates yet, but I believe we're hoping within a month to 2 months to test the system. We're hoping to go live probably with those agencies that tested April. I don't know if we'll be going, depending on how things go, because we will also need to be training everybody as well. So we're not just going to say, hey, here, do this. We will be having some training. So keep up to date with that. We will be sending you messages when that will be going and starting, and when we'll be doing some trainings. We're working currently on a help desk document. And so being part of the testing environment, we'll also be having you look at that to see if there's things that we've missed, because we want to make this as easy as possible and seamless as possible. We don't want to be throwing you guys out there and then having lots of questions. So anybody that wants to volunteer, we will use you. And again, just email us. And I don't know, I'm keeping track of the Q&A. So Julia, please interrupt me if need be. Next is the legislative session. The 2025 legislative session is in full force. Bill analyses have been coming through to a lot of us. So Healthcare Authority, a lot of us are pretty busy with the legislative session. And as you've probably have heard through the news, other state agency webinars, and then a recent message that came out from the governor's office, Washington State is facing a projected budget shortfall of more than 12 billion over the next 4 years. So right now, we don't know of any program changes that will be required, or we will not know if any program changes will be required until it gets closer to the end of the long session and the proposed budget has been completed. In the meantime, we are moving and continuing with the work we've been tasked to do during the last legislative session with regard to Senate Bill 5580, which is increasing the units and increasing the reimbursement rate and updating the screening tool and things such as that. So we are continuing until we hear otherwise, which hopefully, fingers crossed, we will not hear otherwise. But wanted to kind of give you guys an update on that, as I know the news has been a bit depressing lately. And then last, we kind of spoke about this during the doula presentation, but as the doula WAC requires care coordination with MSS providers, so that's one thing I think I saw a question too, is if somebody is not receiving doula services, then there's no care coordination that needs to be taking place. If they are receiving doula services through an Apple Health provider, an Apple Health approved doula, then that care coordination needs to be taking place. And again, we're just going to be adding that into the same language where right now it's already required that it be with a WIC and a client's OB or midwife. So we're not going to put any specifics as to what is going to need to take place at that care coordination or how it has to be done. It's going to continue as it has been, what's going to be best for you. But to keep the CMS happy and to make sure that things are going smoothly for both the client and you guys as providers, that will be an update in WAC. And then I will also be updating the screening tool language now that it'll be completed online. And I believe there's also some face-to-face language that I'll be updating since we do allow the telehealth and the audio only visits. I'll be updating and kind of doing some cleaning up of some of the WAC language. I know I went really fast. Are there any questions?
Looking through the Q&A, I don't see any specific questions related to our updates. Let me just double check. I do not see any specific questions. I do have somebody with a raised hand though, so Tanaya, I will unmute you and then you are unmuted, so go ahead.
Thank you, Heather, for all of these updates. And I know that changing the WAC language is another huge endeavor. So I'm just trying to remind myself if I or other providers go to the MSS website, are there links to the WAC language there? I think there is. I just wasn't sure. So when you make these updates, I'm sure there'll be like an email that goes out, because y'all are always really good at that, so notifying. But then when we get to the page, there'll be a link to the WAC so we can see those updates. Just trying to think
No,
through.
great question. Thank you. Thank you. So, actually the WACs are listed within the billing guide, and so then the billing guide will also be updated.
Billing.
Um,
I love billing guides.
Yes,
Okay, I'm sure.
but if anybody's interested, the thing to remember for our WACs, the chapter that includes a lot of the MSS and ICM, and then some additional pregnancy things that are covered through Apple Health. 182-533. If you just type in WAC, WAC 182-533, you will get the whole complete chapter. That includes the MSS and ICM WACs. So that's definitely a way to look things up too if you don't want to go looking in and trying to find stuff within the billing guide. That's the chapter that MSS and ICM rules and policy are under.
Great, thank you. And I think we are out of time, and I do not see any more specific questions to your updates. If there are additional questions, I am happy to, if you email us, we are happy to answer them. And we will get the YouTube communications to upload to YouTube and get that sent out with the additional webinar materials from today. Heather, do you have anything to add before we close out?
No, just whoever, if you're comfortable, whoever made the comment in regards to clients, the clients reporting pregnancy if they're on Apple Health expansion and what you've been told, if you could reach out to me, because I'd like to get a little more clarification in regards to that, because there's a lot of work we've been doing and more information in regards to Apple Health expansion and pregnancy and 12 months postpartum will be coming out here soon. But I if you're comfortable, if you could email me or send it to that First Steps box, Shirley and I have that. I'd greatly appreciate it if you're still on.
Wonderful. Thank you so much. And we want to thank everyone for joining in. We do appreciate it. And we hope that everyone has a wonderful rest of their day.